All right. Well, it's 12:05, so why don't we go ahead and get started? So as I mentioned before, today's training is going to be led by Dr. Robert Paine, and he's going to be speaking on trauma-informed care. So without further ado, Dr. Paine, I'll turn it over to you, and feel free to share your slides, or I have them here too. If you'd prefer for me to share, let me know.
Okay, thank you so much for introducing me. I'm going to go ahead and share my slides and start my slideshow. So I'm going to just start by introducing what BHIPP is. So BHIPP stands for the Maryland Behavioral Health Integration and Pediatric Primary Care, which is a child psychiatry access program that supports the capacity of primary care providers in Maryland to manage pediatric mental health concerns. We offer free behavioral health telephone consultation. And I like to emphasize free because I think that's a really big deal. And so we also offer resource and referral networking, training and educational opportunities, i.e. today's webinar, as well as some web-based longitudinal learning through Project ECHO, telemental health services, care coordination, and social work co-location in select primary care practices in collaboration with Salisbury University and Morgan State. So we also received additional funding to expand our consultation capacity to address crisis intervention in select hospital EDs and to provide tech assistance to help select primary care practices with goal of practices becoming mental health hubs. So we are also supported by the SAMHSA e-COVID funding. It was granted to address behavioral health issues experienced by children, youth, and families as a consequence of the COVID pandemic. And we operate in a collaboration between University of Maryland School of Medicine, Johns Hopkins University School of Medicine, Salisbury University, Morgan State University, and the University of Maryland Eastern Shore. So my only financial disclosure is that I receive a paycheck as a member of the faculty of the University of Maryland School of Medicine. So our learning objectives for today's talk for the trauma-informed care webinar are to identify the 5 principles of trauma-informed practice, identify 3 ways in which clinical encounters can unintentionally re-traumatize youth and families, and lastly, identify 3 strategies to optimize clinical encounters using the principles of trauma-informed practice. I'd like to acknowledge 2 of my colleagues, Dr. Rihanna Platt and Dr. Sarah Edwards, who created the majority of today's slide content. So first, to start with definitions, the SAMHSA, or Substance Abuse and Mental Health Services Administration, has done a lot of work around trauma-informed care, and for which I have a link at the end for those who are interested. Use the definition you see here. They also describe the 3 E's of trauma that you see at the right here, and this can be helpful to parse out. It separates the event from the individual's experience of the event and the meaning they take of it. For example, when it's something seen as shameful or involving, sense of powerlessness or feeling trapped. And finally, the effects of the trauma, which can be immediate or delayed. So some examples of trauma. This is not an exhaustive list. I'm sure there are a number of different types or examples that we can add to this list, but that would include natural disasters, hurricanes, fires, and floods, community violence, robberies, shootings, assault, gang-related violence, hate crimes, group trauma affecting a particular community would fall in that category, school violence, threats, fights, school shootings, bullying, loss of a student or family member or staff member. We have family trauma, which includes a variety of different types of trauma, including abuse, neglect, experience or witnessing domestic violence, incarceration of family members, family substance abuse, sudden or unexpected losses of loved ones. We also have refugee and immigrant trauma, so exposure to war, political violence, torture, Forced displacement, migration, and acculturation stressors, fears of deportation are examples. We have medical trauma, which I find is under-recognized, in my opinion, which is pain, injury, and serious illness, invasive medical procedures or treatments. We have poverty, which is, examples, lack of resources, support networks, or mobility, financial stressors, and homelessness. We have historical and racial trauma, which would include the experiences of racism, structural and/or interpersonal, generational poverty, slavery, and Holocaust survivors. There is the issue of cumulative trauma, as many of the children that we see experience more than one traumatic event. This is an example of different layers of trauma that might be experienced by an individual. And as you can imagine, the cumulative effect can be wide-ranging, particularly when experienced at an early age. You might hear the term complex trauma, which is a term designated this definition, exposure to multiple traumatic events from an early age. So the ACEs study is well known these days. This was conducted years ago in California, collaboration between Kaiser Permanente and CDC. We were able to, parse out that individuals who experienced cumulative traumatic or adverse experiences, increasing adverse experiences were associated with higher rates of long-term health and mental health effects into adulthood. So, for example, children who experienced 4 or more ACEs are 10 to 12 times at greater risk for IV drug use and attempted suicide. They are 2 to 3 times greater risk for developing heart disease and cancer, 32 times more likely to have learning and behavioral problems. And 8 out of 10 leading causes of death in the United States correlate with exposure to 4 or more ACEs. So this neurobiology of the stress response could be a presentation in and of itself, but I just wanted to show this to put a context to some of the symptoms we will be discussing. It's thought that a number of the effects of trauma are related to the dysfunction of the cortisol system, which is a stress hormone, and the effect that that can have on different areas of the brain, including decreased connectivity between the prefrontal cortex, which has a major role in executive functions, emotional regulation, and other parts of the brain. So a little overview of the effects. These can be wide-ranging, including effects on interpersonal relationships, acquisition and developmental tasks, and physiologic effects. The effects are often increased in cases where trauma occurred early and when the perpetrator is a trusted caregiver. So some signs during different developmental periods that a child may have experienced trauma. So in infancy, this could be developmental delay or failure to thrive. In toddlers, frequent tantrums, aggressive and easily frustrated. And compared to what will be considered normal toddler behavior, these are, normal behaviors in toddlers, but these are way out, way more severe than what would be considered normal. So very frequent and very aggressive, super easily frustrated. In school-age children, this will come to your attention in primary care. Kids having difficulty at school, difficulty with peers and fighting, can look a lot like learning problems in ADHD. We'll talk a lot about that because it's so important, it's so common. We put an asterisk by it because we're going to talk a little bit more about that. And adolescents can have, again, school difficulties, risk-taking behavior, substance use, anxiety, and mood symptoms. So a little bit about trauma triggers. These are reminders of past trauma that automatically, without thinking, reflexively cause the body to react as if the traumatic event is happening again in that moment. Many of the things that you see here on this list may remind patients or family members of past trauma, and they may be things that happen every day in the office or in the school or community. For example, my office is right here on Martin Luther King Boulevard. And there's all kinds of loud noises all day long out here. So that can be just an example of a trigger that's easy to not notice. But as we try to optimize the space to make our spaces more trauma informed, these are some of the things to be aware of. And so the impact of experiencing those triggers can lead to some of the responses described here. So one thing that's, a mnemonic could be the 3 F's of trauma: fight, flight, or freeze. So fighting, yelling, swearing, posturing, aggression. Flight behaviors are running away, refusing to talk. Some people call this shutting down. Avoidance, substance use. And freeze would be spacing out, dissociation, as it's called, appearing numb, disconnected, confused, or unresponsive. So we won't go through all of these symptoms in the interest of time, and you will receive a copy of these slides. But these are some of the core symptoms of PTSD, which have gone through a number of different revisions through the different publications of DSM, our psychiatry diagnostic manual. But the core symptoms include intrusive re-experiencing, which are, I'll describe to my patients, is it like you're having a nightmare while you're awake kind of thing? Because it's almost like they're reliving the experience while they're awake during the day, as well as nightmares at nighttime. Impact on mood and cognitions. So some of the things that people might think: I can't trust anyone. What's the point of talking about any of this? It doesn't change anything. So this pervasive negative cognition that, is pretty fixed until we really work on that in therapy. Of course, a lot of avoidance of certain places and trauma triggers is very important. And symptoms of arousal, hyperarousal, including sleep problems, hypervigilance, irritability, impaired concentration, and aggressive behavior would also fall in this category. But not everyone who experiences trauma develops PTSD, and it varies by the type of trauma, proximity, duration, availability of an adult, and child characteristics. So in psychiatry, we often say trauma is the great imitator because it can really present with, it can really look like most of anything we might see in psychiatry, particularly child psychiatry. And as you can see here, there's significant overlap of trauma with ADHD. And when you think about the impact of cortisol dysfunction on the prefrontal cortex and regulatory functions in the brain, that makes sense. So we have the trauma symptoms over here, as well as ADHD symptoms, and the overlap with a lot of shared characteristics. Well, again, trying to parse out symptom domains, because that can be really helpful from a treatment planning perspective, because it's such a complex, it's a complex problem with a lot of different implications. So you have problems with mood regulation, aggression, attention, impulse control, and sleep. So, a reminder, it goes without saying, but something that bears, its own slide, which is all of our kids we care for in the context of their families and their life circumstances. And many of the kids we see may have parents who have also experienced trauma and who experience challenges in parenting and difficulty with some of the same triggers I described earlier. And so adults who have experienced ACEs in their early years may have changes in their stress response system and diminished capacity to respond to stressors in a healthy way. And so this would certainly present for those of you who work in a primary care setting, parents that seem irritable, hostile, or even aggressive, missing appointments, reluctance to discuss problems, and have a number of needs to address during your visits. These are 4 excellent books about trauma and recovery. And And I just listed them here because I think they're extremely helpful in going into a lot of depth, not only about trauma and its symptoms, but how people get better. And I think that's what we're all here for, is how we can help people move on and find meaning in their experiences so they can live a life, a fulfilled life of happiness. So what do? We use trauma-informed care within a trauma-informed system. And that's what we are hoping to implement. So what is a trauma-informed system? So the SAMHSA encourages, so I encourage you to look at their resources, but to outline a few features of trauma-informed care when we think about how to devise a system that can better meet the needs of traumatized children and their families. They describe the 4 R's of a trauma-informed system, including realizing the widespread impact of trauma and understanding the potential paths for recovery. So underlying the importance of relationships to recovery, and you know, in mental health, where it's all about relationships and rapport building, and that's super, super important. But also we're here today, you know, to recognize how prevalent this is and how important this is. So we're already working on number 1 and number 2. Number 2 being recognizing the signs of symptoms in trauma patients, families, staff, and others involved with the system. So this would, you know, include screening, but also, you know, which we have some screening tools in the slides, but also attending to wellness and resilience, especially within a hospital system and a culture. Thirdly, by integrating this knowledge into policies, procedures, and practices, and how we can address the healthcare environment physically and psychologically, really try to optimize the space, have universal precautions, meaning, you know, treating every patient with this trauma-informed approach, assuming we're seeing a number of trauma patients, which we are, and making information and resources available. I'm going to spend more time on this last one, which is extremely important. We're really trying to be mindful of how our practices can unintentionally re-traumatize patients. So making a very deliberate effort to minimize that to the very fullest extent that we possibly can. So this is kind of different from trauma-specific interventions or treatments, which are designed specifically to address the consequences of trauma and to facilitate healing. I like to think of trauma-informed care as a mindset and a philosophy. So a little bit about screening, you know, in the primary care setting or in the emergency setting, just kind of setting the stage. But first, you know, we just recommend, especially now that we have electronic medical records and there's so much integration in those systems, a trauma history may already be thoroughly documented, in which case you wouldn't necessarily have to ask all the questions again. But, you know, if it's not there, screening for the trauma, normalizing it by letting families know how common it is and that it's okay to talk about. So there could be a single screening question you can use here. Other ways to raise the topic include things like posters and handouts, the NCTSN, which is available in this at the end of this presentation. The information to access that has a bunch of great resources I use quite often. And these are some example instruments you might be able to use in the office or in the emergency setting. So when a family discloses trauma, here are some examples of things that you can say when a family discloses trauma, and recognizing that shame and isolation are often powerful after effects of trauma, and working to counteract that, reassuring them that they're not alone, that the medical home will not be a place for assigning blame, but rather to help support the family and connect them to the services they need. And this is a couple of examples of things you can say. You could further elicit symptoms and provide education. You can ask, what differences have you noticed in your child since the event? and reminding families of common symptoms after trauma, because often, in my experience, I find that simply by identifying some of the consequences, some of the things that the children might be doing, which are just like really unnerving to the caregivers, to understand that there's an explanation for that can be really, healing and reassuring in and of itself, in my experience. So families might require follow-up or referral. So identifying resources ahead of time and linking them with those resources can be extremely helpful. Helping parents cope and, reminding them, it's important to try their best to make time for themselves. I have 2 children, and I understand how hard it is to have any time to myself, but nonetheless, by giving themselves some time to take care of themselves can be really, really important for taking the best care of their kids they possibly can. These resources on NCTSN are regularly updated. So here are the 5 principles of the trauma-informed approach. This is an infographic from SAMHSA. You see that several of the concepts here involve affirmation, autonomy, and control. And these are things missing when a person experiences trauma. Trauma often involves helplessness, isolation, feeling trapped, shame, those kinds of things. So we're trying to counteract those feelings by really working in collaboration with our patients. So a couple of things about potentially re-traumatizing practices. So one essential feature of trauma-informed care is the focus and the prioritization of treatments that do not inadvertently re-traumatize patients. Unfortunately, hospitalizations, whether it's psychiatrically or medically, involve a wide range of standard clinical practices that can iatrogenically trigger trauma symptoms or reenactments. But I think it's important to acknowledge that if we approach our patients from a trauma-informed care perspective and philosophy in everything we do, the patients will tend to present calmer, and they won't have those like iatrogenic triggers like revving up their trauma symptoms. So hopefully we won't have to use things like seclusion and restraint and forced medications. But simple things like making sure you ask for permission to touch, walking into their rooms without knocking, those things can be avoided. Really, our goal and our philosophy is to create an atmosphere that is respectful of the trauma survivor's need for safety, respect, and acceptance, while striving to minimize the possibility of re-traumatization. It's almost like a mission statement. I'm outlining safety because safety is always our #1 priority, but safety for the trauma survivor is even more important. And so acknowledging that an atmosphere that is respectful of their need for safety, respect, and acceptance is fundamental to building trust and therapeutic engagement. And this is really the foundation on which we build our interactions with the patient, is with helping them feel safe first and foremost. So when it comes to performing a physical exam, I think it's important to say, do I have your permission to examine you? Not assuming that it's, the consent to perform the exam is implied, but, explicitly getting that consent can really go a long way. And also communicating to the patient that they may stop the exam at any time, because they might feel comfortable at first, but then, the exam continues and they start feeling flooded, they start feeling triggered, and they can tell you to step back and to stop. And also, by checking in throughout each step of the exam, we can make sure that that's not happening. Explaining every step of the exam in advance helps them kind of know what's coming, so they can help keep themselves regulated. For example, now I'm going to put the stethoscope on your chest to listen to your heart. Again, knocking before the room or entering the room, something that we were taught way back in medical school, but after a while it can get, especially in the ER, if there's those curtains, but I think you can knock like on the side, like on the wall where the door is. Offering a chaperone, there's my kids go to Kaiser and they have like signs everywhere about chaperones. But simply offering a chaperone, especially with more invasive procedures like pelvic exams, is extremely important. And at a teaching hospital like this one, really important to obtain consent to have trainees present during the exam before they're there, because it can be really awkward for the patient to say, no, I don't want any of you all in here. Can you please leave? Again, giving them that choice before they have to confront the students, which can be really awkward and uncomfortable. So the million-dollar question is, how can we safely de-escalate an agitated patient without using medication, seclusion, or restraint? Some general considerations. We'll really try to optimize the use of environmental and behavioral techniques to the fullest extent possible, with the emphasis on effective communication and behavioral strategies for managing behaviors. Always treat the underlying cause of agitation first whenever possible, before medication, and if absolutely necessary, we can use PRN medications if those avenues are not successful. So in the treatment of agitation in pediatrics, there's an algorithm that was developed, a set of expert consensus guidelines where they were able to identify this three-step paradigm approach. So in number one, the patient is verbally engaged. When you verbally engage the patient, then a collaborative relationship can be established. And then the patient is verbally de-escalated out of the agitated state. But it's really, the foundation and the essential component is having them verbally engaged and being able to converse. If patients are shut down or not able to verbally engage, then this really can't happen. So oftentimes, on our inpatient unit, sometimes we give the kid like a few minutes to, of space so that we can check back in, see if they're willing to verbally engage at that point. So verbal de-escalation is usually the key to engaging the patient and helping them become an active partner in their evaluation and treatment. So some really step-by-step principles of verbal de-escalation. Number one, respect personal space of the individual. Do not get uncomfortably close or block exits. Number two, do not be provocative or respond in anger. Be in control and measured. Three, establish verbal contact calmly with the individual. Number four, be concise and speak in short, easy to understand sentences or phrases, repeating yourself often. Listen closely to what the person is saying. Identify the individual's wants and feelings and try and accommodate reasonable requests. Agree or agree to disagree with the person's concerns while avoiding negative statements. This can be really hard to do, but sometimes we have to sort of just like let things slide, especially when we're working with kids who may be agitated or in crisis. While avoiding negative statements, that can be potentially, we'll call it a trauma trigger. It's important to set clear limits with expected outcomes, but do not make demands or order specific behavior. Offer choices and optimism, and afterwards review the event and look for areas of improvement. Okay, so that is the end. We have plenty of time for discussion, hopefully for people to eat before they have to get back to work. And here are some resources at the end. Here is NCTSN, the Trauma-Informed Care Implementation Resource Center. And these are also really great too. stop share so I can see you all. All right.
Great. Thank you so much, Dr. Paine. That was a wonderful presentation. We are monitoring the chat, so if you have any follow-up questions for Dr. Paine about his talk, please feel free to drop those in the chat now. You might notice that Naomi has put a number of links in the chat to some of the sources that appear in the presentation. And we'll also be sure to have these available for you on our website when we post the slides and recording from today. We have a compliment for you here, Dr. Paine. Thank you, very informative. No questions. I do want to say I really like the information provided in the webinar.
Thank you.
Here's a question. How can you get school teams to add trauma-informed care into supports and services for students with disabilities?
Yes, super important. So one thing that we're going to be working on as a group is hopefully going to come up with some, a resource page and some ways we can apply trauma-informed care principles to settings, including schools. Within the context of the school system, I find that kids who have trauma will end up having a, I think the IEP designation for a lot of those kids is emotional disturbance. And those kids tend to get certain services like individual counseling, should have an opportunity to, find space to, re-regulate themselves, other things that might be helpful for them. For a while, I used to be the mobile crisis psychiatrist, and I used to give out this putty, which is like, it's like a fidget. This is before COVID, so it's not necessarily, but it's I mean, this is one example of something that kids can do when they're feeling like really upset. They can, so potentially something like that can be written into their IEP so that they can, somehow regulate themselves with their hands. Some of my super impulsive ADHD kids, though, because this is like sort of like a rubber bouncy ball, so that can be challenging when they throw it down the hallway at school, but in which case you might have to take it away. But yeah, within the school context, but also I think the whole school system having awareness, just like I said with the 4 R's, I think everyone has to be on the same page. So I think school systems have to do a lot of this work too, to, recognize how this this trauma history might be impacting kids in school. And, one thing we teach our trainees and the people we work with is, if things aren't improving with ADHD medication, for example, we have to be very mindful that there might be something else going on, including trauma.
Just to add to what you're saying, Dr. Paine, I think if the trauma is known to the school system already, I think that should be explicitly, accommodations should be explicitly discussed during the IEP or 504 meeting. And so sometimes that means that the child need to have some kind of an advocate there who's able to explain what trauma informed care means. And so that might be the school counselor, the school psychologist, it could be the parent, and we also have advocates through organizations such as Maryland Coalition of Families that, do attend those meetings and help support families when needed. We did get another comment that's kind of related to what you just said, Dr. Paine. A reminder that symptoms we are seeing in a new student could be trauma related and not just ADHD oppositional behavior. So that's important to kind of keep that as a differential right from the beginning.
Absolutely. And another thing in one of the books I linked, The Body Keeps the Score, he talks about how children and adolescents, I think only about 40% of those kids who experience trauma actually disclose that trauma and endorse that trauma. So there's, a large percentage, the majority of those kids who are not going to endorse that they experienced a traumatic event, but nonetheless they have trauma symptoms. So I think we have to be very mindful of that, and also, you know, similar to the universal precautions, when we're seeing things that are trauma triggers, trauma symptoms, you know, the where there's smoke, there's fire kind of thing. Not assuming that families have experienced trauma if they didn't endorse it, but nonetheless, if we're working with a kid in a family and there's some of this stuff going on, we can, have that working assumption in place and continue to try to get them to talk about it, but it might take a long time for them to finally disclose.
Just to follow up on the previous question as well regarding school-based services, our next crisis webinar in January 19th, is going to be on school-based mental health resources. So a member of our school-based mental health team at University of Maryland, Jill Bonenkamp, is going to be speaking. And so in preparation for her talk, I'm happy to share these questions with her because she might have a more detailed response or some recommendations for us around that and how to engage the school better.
Great.
Okay, we have a specific question. My child is diagnosed with ADHD and had an IEP, now has a 504 plan. However, the services they provide are more focused on giving the teacher information, tools, etc., to better work with her in the classroom rather than providing services to her directly. It seems unhelpful to me. Do you really think this is enough to really help a child who is struggling to focus while working individually in class?
Yeah, that's a tough one. One of the things that, when I'm treating patients, trying to give them a lot of resources, not only things like Attitude magazine, but also there's a couple of books I have behind me. I don't like turning my back on the audience, but one's called Taking Charge of Your ADHD, Russell Barkley, has a lot of strategies in there. Because, a big component of ADHD treatment is, organizational strategies, planning, therapeutic strategies, things that the school might not be doing on the individual level. Like you said, it's sort of managing how information is presented, the tasks that they're required to complete, and etc. But for the actual child in their mind, it's not as helpful. So certainly a difficult problem, but that's something that I could recirculate to some information that I usually provide the families.
I just want to add to that during the, it looks like they have a 504 now, during the meeting, you can advocate for your child as their parent and say, I really think that this isn't meeting my child's needs, and I think that they need more, individualized assistance with these symptoms. And the school can, hopefully be open to working with you around that. Maybe they can be meeting with the school psychologist or school counselor or special educator around that. I did miss a question. I just scrolled back up. So I apologize. It says, great presentation. My most difficult challenge is integrating seasoned staff into use of TIC, changing old school behavioral approach and mindsets regarding reward and consequences related to rules and policies on an inpatient behavioral health unit are difficult. Any suggestions?
Yeah. Yeah, that's I think that's, that's a tough one because, the old school versus new school way of doing things, that can be really, really challenging. But one thing that we can maybe say is that, like we can all agree that what we're doing might not be working. So trying to, step by step address with individuals who might be a little bit more resistant, more old school, kind of set in their ways. Like, let's think about other ways we might be able to approach this because I'm not really so sure that we're doing, things in the most cutting edge way. And we all want, like, also really trying to find common ground. We all really care about the kids. We're all trying to help them. Let's see if we can help them this way.
Mhm.
But simply trying to level with people, trying to not find that common ground first, and then move forward. It might take some time, but I do a lot of work with the Department of Juvenile Services and kind of similar stuff that we see there. It's even harder because I'm doing a telepsychiatry approach, so I'm not actually physically in the building, but nonetheless still have a lot of, education to provide about what this is and how we can help with these really old school approaches and how we can maybe modify those. But it is very difficult.
Mhm. I wonder if there would be a way to ever put in a request for, I know sometimes staff are asked about what topics would you like to see have somebody come in and talk about for like an in-house CME event or something. You could request that, and that way it's coming from like a, more neutral party.
Yeah,
And you don't have to feel like you're getting into like a challenge with your coworkers. Um,
that's a great point.
I saw another question here. We're getting a lot of great questions today. How would you recommend teaching staff educate student peers of a traumatized student who may be experiencing or may be exhibiting re-experiencing behaviors that are disruptive to an entire classroom? Some students tend to avoid students with large emotional outbursts and may not understand what's happening. And in turn, sometimes this leads to the traumatized child feeling rejected by their peers.
Mm. Yeah. Yeah, from a school's perspective, I think having a debriefing with the kids is important, but also presenting the information in a way that's, like at their developmental level. So depending on which age group you're, working with, there's a couple in our manual of like addressing traumatic stress in children and adolescents, the ARC, attachment regulation and competency manual. I think there's some really good stuff in there about like psychoeducation for kids and the way it's worded. Um, we can actually have the ebook, but I'm not sure if I can actually share that without like, violating copyright laws. But I'm pretty sure we can link that specific book to the chat. And I think there is a similar book about working in schools specifically. But I find that, trying to peruse some of this information, and it can be really helpful for, you know, like how can we present this information depending on the school age child versus adolescent. Um, that has some good stuff in there. But for sure, I think just first of all, acknowledging it and making attempts to help the students understand I think would go a long way.
I'm continuing to take some notes for our next training. So this is really helpful as we, focus in on more school-based resources for the next crisis webinar. We have another couple minutes and we're happy to stay on if folks have more questions. At the end of today's webinar, Naomi's going to be putting the link to our post-webinar survey in the chat that you will need to complete for CMEs. And we did get another question here. Are there any strategies you recommend to help reduce feelings of shame students may feel after re-experiencing behavior occurs?
Yeah, that's another good question. I think, again, the psychoeducation component that, when they lose control of themselves, first of all, kind of just acknowledging, I think shame is healthy in some cases, like if they do something and having feelings of guilt afterwards and knowing that's coming from a healthy place because, that's motivating for them to work on changing it, but also to not like be too hard on themselves. So I think first of all, just saying like we all know that you're doing the best you can, and your body sometimes takes control of what you do without you being like aware of it or being able to stop yourself. And so I think because they feel so shamed and guilty, helping them understand that their trauma and these symptoms and these triggers are really they set them up to go on autopilot. And I think by telling them basically it's not their fault, um, the bottom line. But from like a DBT, dialectical behavioral therapy perspective, one thing that like a big component of that approach is like their problems might not be like their fault in and of themselves. It's still their responsibility to work on changing them because those seem like polar opposite ideas, and that acknowledging that they are struggling, that this isn't their fault, they're trying, but we need to keep working on this. So I think that that's kind of the general message that I would use with that kind of situation. We really appreciate everyone's really great questions, and hopefully this is setting up for like next time on BHIPP crisis training, like for our school-based talk, because this is really great. It's really great, thought-provoking questions. Certainly appreciate everyone's attention and time today.
We are able to stay on until the end here, but just want to draw your attention to the chat where Naomi has included a link to today's training survey, post training evaluation survey, excuse me. And also she's included a link to our website. And after we are able to download the recording from today and post that, we'll post that along with the slides and any other resources. So our CME and CEU certificates will be sent out via email within 3 business days of completing the evaluation, along with a link to the recording, slides, and related resources. Our next crisis training webinar is going to be held on Thursday, January 19th. And again, the topic for that is school-based mental health. Naomi has also included a link to our social media sites here. Share what you learned from today's BHIPP mental health crisis training on social media. Tag us and be entered to win a free water bottle. Wonderful. Some folks have already registered for our next training. Thank you everyone for all your kind words and feedback. We'll stay on for the next 3 minutes just in case anyone thinks of anything else they want to ask about. Someone was asking, could you please put the book name recommended to use with students for psychoeducation? I wrote down ARC, but I don't see the book link.
Yes, I'll do that right now.
All right. So that link just came through and it is 1 o'clock. We're going to go ahead and conclude today's session. Thank you so much, everybody, for joining, and thank you, Dr. Paine, for a wonderful presentation.
Thank you all so much. Happy holidays. Bye.